Dr. Amanda Pierce stood in the corner of the emergency department break room at midnight. Her surgical scrubs wrinkled from a 16-hour shift that should have ended 8 hours ago. The fluorescent lights flickered overhead, casting harsh shadows across her face as she stared at the disciplinary letter in her trembling hands. The words blurred together through her exhaustion, but the message was crystal clear. Final warning for insubordination and failure to follow established protocols. Around her, the night shift moved with practiced efficiency. Nurses restocked supply carts, residents huddled over patient charts, and the constant hum of medical equipment provided the soundtrack to another chaotic evening at Metropolitan General Hospital. But Amanda felt completely alone, isolated by the weight of decisions that had saved lives, but cost her everything else. 3 months ago, she had been the rising star of the surgical department. Fresh out of her trauma surgery fellowship at Johns Hopkins, she'd arrived at Metropolitan General with stellar recommendations and the kind of innovative thinking that teaching hospitals claimed to value. Her techniques were flawless, her diagnostic skills exceptional, and her dedication to patient care was absolute. But none of that mattered now. The letter detailed her infractions with clinical precision. Failure to consult attending physician before proceeding with experimental procedure. Unauthorized deviation from standard treatment protocols. Inappropriate assumption of authority during medical emergency. Each accusation was technically accurate, but they painted a picture that completely ignored the 3 lives she had saved using methods that existed outside the comfortable boundaries of textbook medicine. Amanda folded the letter carefully and slipped it into her coat pocket. Through the break room window, she could see the emergency department's controlled chaos continuing without pause. Ambulances arriving, patients being triaged, families waiting for news that would either shatter or restore their worlds. This was where she belonged, where her skills could make the difference between life and death. But her future here was hanging by the thinnest of threads. Dr. Harrison Webb, the chief of emergency medicine, had made his position clear during their meeting earlier that day. Metropolitan General was a prestigious institution with a reputation to maintain. They couldn't afford to employ physicians who believed rules were suggestions rather than requirements. The fact that her unconventional methods had achieved positive outcomes was irrelevant if those methods undermined the structured approach that kept the hospital functioning. The irony wasn't lost on Amanda. She had spent 7 years in medical school and residency learning to think critically, to adapt to unexpected situations, to prioritize patient welfare above all else. But when she had applied those principles in real-world scenarios, she found herself facing disciplinary action for being exactly the kind of doctor her education had trained her to become. Her phone buzzed with a text message from her mentor, Dr. Sarah Chen, who had recommended her for the position at Metropolitan General. The message was brief but supportive. Heard about the meeting with Webb. Don't let them break your spirit. You're exactly the kind of doctor patients need, even if administrators don't understand that yet. Amanda appreciated the encouragement, but it didn't change her current reality. She was one mistake away from losing her job, one protocol violation away from having her medical career derailed before it had truly begun. The weight of that possibility pressed down on her shoulders like a physical burden. The break room door swung open and Dr. Marcus Rodriguez entered, looking as exhausted as Amanda felt. Marcus was a third-year resident who had been present during all 3 of the incidents that had led to her current predicament. He poured himself coffee from the perpetually brewing pot and sat down across from her. "You look like someone who just received bad news," Marcus said, his voice carrying the kind of weariness that came from too many consecutive hours in a hospital. Amanda managed a weak smile. "Just reviewing some administrative feedback." Marcus studied her face with the diagnostic eye of someone trained to read subtle signs of distress. If you're talking about the disciplinary letter, half the department knows about it. Word travels fast in a place like this. Amanda wasn't surprised. Hospital gossip networks operated with the efficiency of emergency response systems. By tomorrow, everyone would know that the promising new trauma surgeon was on thin ice with administration. The thought of becoming the subject of whispered conversations and knowing looks made her stomach clench. For what it's worth, Marcus continued, what you did for those patients was remarkable. I've never seen anyone work with that kind of precision under pressure. You saved lives that would have been lost if we'd followed standard protocols. Amanda appreciated his support, but she also knew it came with risks. Marcus was still a resident, vulnerable to the same administrative pressures that now threatened her career. Speaking up for her could jeopardize his own future. The problem isn't my surgical skills, Amanda said quietly. The problem is that I can't seem to operate within the system without challenging it. And apparently that makes me a liability rather than an asset. Marcus leaned forward, his expression serious. Maybe the system is what needs to change, not you. Before Amanda could respond, the overhead speakers crackled to life. All available medical staff to emergency department, multiple trauma inbound, mass casualty event at downtown construction site. ETA 4 minutes. The familiar surge of adrenaline cut through Amanda's exhaustion like electricity. This was what she lived for. The moments when everything else faded away except the immediate need to save lives. She stood up, automatically checking her pockets for the tools she would need. Marcus was already moving toward the door, his fatigue forgotten in the face of incoming emergency. They walked quickly through the corridors, joining the stream of medical personnel converging on the emergency department. The trauma bay was transforming before their eyes. Nurses cleared unnecessary equipment, anesthesiologists checked their supplies, and residents positioned themselves at assigned stations. The choreography of emergency medicine was beautiful in its efficiency, each person knowing exactly where they needed to be and what they needed to do. Dr. Webb appeared at Amanda's side, his expression all business. Dr. Pierce, you'll assist Dr. Matthews in Trauma Bay 3, follow his lead, support his decisions, and document everything. His tone carried an unmistakable warning. This was her chance to demonstrate that she could work within the system, that she could be the team player the hospital required. Amanda nodded her understanding, but even as she agreed to the restrictions, she felt a familiar tension building in her chest. What if following protocols meant losing a patient who could have been saved? What if the safe, approved approach wasn't enough when lives hung in the balance? She pushed those thoughts away and focused on the immediate task of preparing for whatever was coming through those doors. The radio crackled with updates from the incoming ambulances. Construction accident involving structural collapse. 5 casualties confirmed. Severity unknown. First unit arriving in 2 minutes. Amanda took her position in Trauma Bay 3, where Dr. Matthews was already reviewing emergency protocols with the nursing staff. Through the glass doors, she could see the first ambulance approaching, its lights cutting through the darkness like beacons of urgency. In less than 2 minutes, her skills would be tested once again. The question wasn't whether she could save lives that others might lose. The question was whether she could do it while staying within the boundaries that her career now depended upon. The doors burst open and the first patient arrived, beginning what would become the most challenging hour of Amanda Pierce's medical career. The gurney wheeled in, carrying a man in his 40s, his construction vest cut away to reveal a chest that rose and fell in irregular, labored patterns. Blood soaked through makeshift bandages applied by paramedics, and his face had the waxy pallor that Amanda had learned to recognize as a sign of significant blood loss. Construction beam fell across his torso, the paramedic reported breathlessly. Possible internal bleeding, fractured ribs, pneumothorax on the right side. BP started at 90/60, now dropping to 70/40. He's been conscious, but increasingly confused. Dr. Matthews moved to the patient's side, his hands already gloved and ready. Amanda positioned herself where she could assist while staying within her assigned role. But as Matthews began his assessment, she found herself cataloging details that seemed to escape his immediate attention. The pattern of bruising across the patient's abdomen suggested more than simple compression injury. The way his breathing hitched at specific intervals indicated potential diaphragmatic involvement. "Get me a chest X-ray and abdominal CT," Matthews ordered. "Start 2 large-bore IVs and push normal saline." Amanda watched him work with competent efficiency, following exactly the protocols that any emergency physician would employ in this situation. But something nagged at her, a collection of subtle signs that didn't quite fit the standard presentation. The patient's eyes found hers across the trauma bay. "Help me," he whispered, his voice barely audible above the controlled chaos surrounding him. Amanda squeezed his hand reassuringly, noting that his pulse felt thready and rapid beneath her fingers. His skin was cool and slightly clammy, confirming her suspicion that he was sliding deeper into shock, despite the fluid resuscitation. Matthews studied the X-ray images as they appeared on the monitor. "Definite pneumothorax," he announced, preparing for chest tube insertion. Amanda positioned the sterile tray as requested, but her eyes remained fixed on the imaging. There was something else there, a shadow that didn't belong, positioned in a way that suggested complications Matthews hadn't yet recognized. The chest tube went in smoothly, releasing a rush of air that partially re-inflated the collapsed lung. The patient's breathing improved immediately, his oxygen saturation climbing from 85% to 92%. Matthews smiled with satisfaction as the monitors showed stabilizing vital signs. But Amanda noticed that the blood pressure improvement was temporary. Within minutes, it began dropping again despite continued fluid administration. The patient's level of consciousness was also declining, his responses becoming increasingly sluggish. She opened her mouth to voice her concerns, then remembered Webb's warning about following protocols and supporting the lead physician's decisions. The CT images loaded onto the workstation, revealing the full extent of the patient's injuries. Matthews pointed to areas of obvious damage while explaining his treatment plan to the nursing staff. "Free fluid in the abdomen indicating internal bleeding," he said. "We need to get him to surgery immediately for exploratory laparotomy." Amanda studied the scans more carefully, her trained eye picking up details that the initial review had missed. The fluid collection wasn't distributed in the pattern she would expect from simple internal bleeding. There was also an irregularity in the diaphragm that suggested a tear, potentially allowing abdominal contents to migrate into the thoracic cavity. This combination of injuries would require a fundamentally different surgical approach than the standard exploratory procedure Matthews was planning. "Dr. Matthews," she said carefully, keeping her voice respectful and collaborative, "I'm wondering if we should consider the possibility of diaphragmatic rupture given the mechanism of injury and the fluid distribution pattern on the CT." Matthews glanced at the scans again, his expression showing mild irritation at what he perceived as unnecessary second-guessing. "The imaging shows free fluid consistent with internal bleeding," he replied firmly. "The priority is getting him to surgery to control the hemorrhage. We can address any additional findings during the exploratory procedure." Amanda felt the familiar tension building in her chest. She could see what needed to be done, could envision the specific surgical approach that would give this patient the best chance of survival. But her recent disciplinary action had stripped away her authority to challenge treatment decisions, leaving her in the agonizing position of watching while potentially inadequate care proceeded. The patient's condition continued to deteriorate despite Matthew's interventions. His blood pressure dropped to 60/30, and his heart rate climbed above 140 beats per minute. The monitor alarms began sounding with increasing frequency, creating a soundtrack of medical urgency that filled the trauma bay. "We need to move faster," Matthews said, his confidence beginning to show cracks as the patient failed to respond to standard treatment protocols. "Get surgery on the line and tell them we're coming up now." Amanda helped prepare the patient for transport, securing lines and ensuring all monitoring equipment was properly connected. But as they prepared to leave the emergency department, she noticed something that made her blood run cold. The patient's abdomen was becoming visibly distended, and there was a subtle change in the quality of breath sounds on the left side. These weren't the signs of simple internal bleeding that could wait for surgical exploration. These were the signs of a rapidly expanding problem that would kill the patient before they could get him to an operating room. Her hands moved almost without conscious thought, palpating the patient's abdomen and noting the firmness that indicated significant fluid accumulation. The distension was increasing by the minute, and the patient's mental status was declining proportionally. She had perhaps 10 minutes before irreversible shock set in, maybe less. "Dr. Matthews," she said with more urgency in her voice, "I think we need to consider immediate intervention here. The abdominal distension and hemodynamic instability suggest we may not have time for transport to surgery." Matthews paused in his preparations, clearly torn between his treatment plan and the mounting evidence that something was going critically wrong. The patient's vital signs continued to deteriorate, and even the nursing staff was beginning to look concerned. The monitors painted a picture of a man whose body was shutting down despite their best efforts. "What are you suggesting?" Matthews asked, his earlier dismissiveness replaced by genuine uncertainty. Amanda looked at the patient, at the monitors showing his failing vital signs, at the clock on the wall that seemed to be moving too quickly. She thought about Webb's warning, about the disciplinary letter in her pocket, about the career that hung in the balance. Then she thought about the man lying on the gurney, whose life depended on decisions made in the next few minutes. Some choices transcended administrative concerns and protocol requirements. Some moments demanded that a doctor be exactly what their training had prepared them to become, regardless of the consequences. "I'm suggesting we need to act now," Amanda said, her voice carrying a quiet authority that filled the trauma bay, "before it's too late to save him." Matthews stared at her for a moment that stretched like an eternity, while the patient's blood pressure continued its deadly descent. The trauma bay had gone quiet, except for the relentless beeping of monitors and the soft hiss of oxygen flowing through the mask covering their patient's increasingly pale face. Amanda could feel the weight of everyone's attention focused on her. The nurses, the residents, even the orderlies who had paused in their duties to watch this confrontation between protocol and instinct play out in real time. She knew that whatever happened in the next few minutes would define not just this patient's fate, but her own future in medicine. The patient's breathing became more labored, each rise and fall of his chest requiring visible effort. His eyes had lost focus, staring at the ceiling with the glassy look that preceded complete cardiovascular collapse. Amanda placed her stethoscope on his chest and listened to breath sounds that confirmed her worst fears. The diaphragmatic tear was allowing abdominal contents to compress his left lung, while continued bleeding filled his peritoneal cavity with blood that his body couldn't afford to lose. "Dr. Pierce," Matthews said quietly, his voice tight with uncertainty, "if you're thinking about proceeding with emergency surgery here in the trauma bay, you know that's completely outside our protocols. We don't have proper sterile conditions, we don't have the right equipment, and most importantly, we don't have authorization." Amanda looked at Matthews, then at the dying man between them. The monitors screamed their warnings, while precious seconds ticked away. She thought about the disciplinary letter in her pocket, about Webb's threats, about the career she'd worked so hard to build. Then she thought about the 3 patients she'd already saved by refusing to accept the limitations others tried to impose on her healing hands. Sometimes being a doctor meant choosing between saving your career and saving a life. Amanda. Pierce had already made that choice 3 times before, and as she reached for the scalpel, she realized she would make it again without hesitation, because some battles are worth fighting regardless of the cost. What would you have done in Amanda's position? When protocol conflicts with instinct, when careers hang in the balance against lives that could be saved, where do you draw the line? Tell us in the comments below, and make sure to subscribe for more stories about doctors who refuse to give up when everything is on the line.